Good morning, good afternoon, good evening to everyone around the world, and welcome to our ACNS YNS webinars. Today, our chair is Professor Abuzer, who is the Associate Professor of the CGS Medical College and KEM Hospital in Parel in Mumbai. For the two speakers of today, our first speaker is Dr. Kamila Mussabekova, JCS National Center of Neurosurgery, Astana in Kazakhstan, and a neurologist specializing in neurodegenerative diseases. Her talk is the role of metabolic factors in cognitive decline, correlation with neuropsychological assessment skills. Our second speaker is Professor Abuzer, who is a professor of neurosurgery of the Medical Park Ventricular Hospital in Istanbul in Turkey. He's also the chair of WFNS Young Neurosurgeon Forum Committee. His talk today is the white matter guided strategy for the management of ventricular lesions. And after the two presentations, our chair Abuzer will also give a one-point lesson on the white matter fiber dissection. And our discussant today is Professor Oli Singh, who is the professor and the chief of the Neurological Center in Clinical Hospital Ventricular, and he's also the president of Ukrainian Association of Neurosurgeons. And he's the associate professor of the Department of Neurosurgery at Supik National Health University. Our second discussant is Professor Fusao Ikawa, who is the chairman and deputy director in the Department of Neurosurgery, Shimini Prefectural Central Hospital. He's also a visiting professor of the Department of Neurosurgery in Shimini University Faculty of Medicine, Department of Neurosurgery and Graduate School of Biomedical and Health Sciences of the Hiroshima University. With that introduction, I invite our chair, Professor Abuzer, to start our webinar.
Thank you, Ben. Thank you, Professor Kato, for inviting me to be the chair today. Start with the first talk. As Dr. Abuzer has not yet joined, we will start with Dr. Kamila, who is going to be talking on the role of metabolic factors in cognitive decline and correlation with neuropsychological assessment scales. Dr. Kamila?
Yes, thank you so much. Thank you for this opportunity. My name is Kamila Mussabekova. I am a neurologist from Astana, Kazakhstan, and this is my today's title is Metabolic Factors in Cognitive Decline. As we know, cognitive decline is a progressive process, and 55 million people in the world, affects people worldwide, are living with dementia, and more than 10 million people, new cases are every year. Above 40% people of dementia are potentially living, and we see every year more than 50% cases. Cognitive decline developed gradually from normal to subjective decline. After that, this is mild cognitive impairment, and after that we see dementia such as mild and severe. This slide illustrates that we have modifiable risk factors such as hypertension, diabetes, obesity, dyslipidemia, physical inactivity, smoking, depression, hyperhomocysteinemia, and others. This is risk factors in dementia. This is insulin resistance. We have some neurotoxic mechanisms, especially insulin resistance impaired neuronal glucose uptake and leads to energy deficit. After that, we see that tau hyperphosphorylation produced, and also beta amyloid production. And insulin resistance activates inflammatory cascades with interleukin 1b, TNF alpha, and NFKB. Also, insulin resistance activates mitochondrial dysfunction and oxidative stress. In the brain, we see that hippocampal glucose metabolism drops 20 and 25%. And after that, we see that decreased neuroplasticity and the neurogenesis, because with insulin resistance, we see that brain-derived neurotrophic factor, this is factor which includes key roles in neuroplasticity, decreased. Also, gray matter volume in memory decreased. This is, as we know, cardiovascular factors is also very important role because chronic hypertension leads to cerebral microvascular injury and lacunar infarcts. Atherosclerosis leads to chronic ischemia and silent infarcts, and also heart failure reduces chronic hypoperfusion. This is our neuroinflammation. Neuroinflammation is a key role in their neurodegeneration, such as Alzheimer's disease and also mild cognitive impairment. Because first step is metabolic stress. After this metabolic stress, we see that microglial activation is our cytokines, such as interleukin 1b, TNF alpha, interleukin 6, and CRP. And after that, we see that our oxidative stress increased. And after that, we see tau hyperphosphorylation, also beta amyloid. Also, homocysteine is this so important molecule because it's a sulfur-containing amino acid naturally produced when body breaks down methionine. This is a building block found in meat, eggs, and dairy. It's not obtained from food, only made internally. Normal reference is 10, below 10 and 15 millimole per liter. Hyperhomocysteinemia is defined as 15 mol per liter. Levels rise with age, poor diet, especially low B12 and folate, kidney disease, and smoking. This, for example, in the right side, we see scientific evidence for the hazard ratio of 2.25 means that of dementia homocysteine. Second meta-analysis of 9 prospective studies, for example, approximately 7,000 patients, approximately 9 or 10 years follow-up. This is meta-analysis shows that elevated homocysteine increases the risk of cognitive decline by about 1.5 times. And every 5 micromoles per liter increase in homocysteine is associated with a higher risk of dementia. Also, minus 53 percentage by vitamin therapy can reduce brain atrophy by more than half. And epigenetics is so important for patients with Alzheimer's disease and other vascular dementia and other types of dementia because elevates homocysteine accelerates our DNA methylation and aging clock. This is homocysteine mechanisms and therapy. I told that homocysteine is normal. It's for example 6 or 10 references. But if homocysteine rises than 15 millimole per liter, we see hyperhomocysteinemia. First, homocysteinemia activate endothelial injury. After that, we see cerebrovascular and our brain damage. After that, we see that NMDA receptors hyperstimulation and activates excitotoxicity. And after that, we see that beta amyloid or tau phosphorylation increased. This is new mechanisms in neurodegeneration. This is lithium. Lithium is a molecular mechanisms of neuroprotection, and lithium has so many mechanisms. One of the most mechanisms, lithium is inhibition glycogen synthetase kinase 3B ferment, and also activates brain-derived neurotrophic factors. Then activates synaptic plasticity. Lithium is a small ion that acts inside neurons and modulates multiple intracellular pathways due to its small size and similarity to sodium as a natrium. Lithium easily crosses the blood-brain barrier via iron transport mechanisms. The key mechanisms as inhibition of GCK3 beta, which reduce tau phosphorylation and amyloid production. Lithium acts as a multimodal neuroprotective agent and may have disease-modifying potential. And lithium also have not only GCK3B kinase inactivates, also anti-inflammatory effects such as decreased NF-κB activation and decreased interleukin-6, interleukin-1b, TNF-alpha, and also modulates macroglial phenotype from M1 pro-inflammatory to M2 neuroprotective mechanisms. Also, lithium key role in epigenetics and IMP base and the mitochondrial activity. This is our lithium evidence, especially in 2011 for Lenza et al. This is randomized controlled trial evidence. Patients with amnestic for mild cognitive impairment, 45 patients, 24 patients with amnestic mild cognitive impairment and 21 patients with placebo during 1 month treat with microdosing lithium, and after that we assess cerebrospinal flight. In cerebrospinal flight, in this evidence, doctors see that tau is increased and cognitive stability. After that, we see second evidence. This is microdose lithium, especially 300 milligram lithium per day, duration 15 months. Patients with these patients, not mild cognitive impairment, these patients with Alzheimer's disease, and this but lithium group in 2025. This is very big evidence. We see 18 patients with mild cognitive impairments, and these patients treat with also microdosing lithium and check amyloid PET and 7 Tesla MRI, but it evidence not finished, it's ongoing, and I believe that results it will be good. This is my clinical cases. This female patient with progressive cognitive decline over 2 or 3 years, and these patients had a memory impairment, problem with attention, depressive symptoms, and some psychomotor slowing as a hallucination and a sleep disturbance. And I assess you with Montreal Cognitive Impairment Scale, and in the August 2025, I see result 4 with MoCA scale and MRI, check MRI, and after that an MRI, as we see cortical subatrophy, especially in the temporal lobe, and some microangiopathy, and we assess your genetics platform. Genetics platform see that she had ApoE3, E4 genotypes, and check laboratory findings such as vitamin D. She had vitamin D deficiency, elevated homocysteine, low lithium level, and after I treat her with diet, ketoflex diet, with physical activity, control arterial hypertension with drugs, anticholinesterase drugs, donepezilum, memantinum, and for your depression, we treat with escitalopramum and vitamin complex, and after that we treat with lithium orotat, 5 milligram daily, 2 months, and nowadays, and after 2 months, she come to me, and we check your MOCA scale. MOCA scale increased from 2. MOCA increased by 3 points, from 2 to 7, and we observed an increase in lithium levels after treatment, and the homocysteine levels decreased from 16 to 10, and the vitamin D increased from 25 to 50 nanogram. This is also new evidence because omega-3 index, it's so important, it's essential for our neurons, for our membrane, for neurons, and omega-3 index, EPA, and eicosapentaenic acid and docosahexaenic acid as a percentage of total RBC fatty acid, and optimal range is above 8%, while low index below 4% are associated with accelerated brain aging and reduced gray matter volume. And cognitive impact, DHA is especially important for the brain. When DHA levels are low, it's linked to impaired memory, slower processing speed, and 2 to 3-fold increased risk of dementia. And as we see, this Framingham evidence in 2012, low DHA levels leads to 26 smaller hippocampal volume. In addition, the more risky meta-analysis leads that conclusion that supplementation slows cognitive decline in patients with mild cognitive impairment by approximately 50% over 6 months. This is also my cases. This patient, female patient, 16 years old. The patient diagnosis Alzheimer's disease, amnestic form, and the patient presented with progressive cognitive decline, including memory impairment, reduced attention, and decreased daily functioning. On cognitive assessment, her MOCA score was 80 points, and MMSE score 70 points, indicating mild to moderate cognitive impairment. And after I check your omega-3 index, omega-3 laboratory omega-3 was significantly low at 1.38%, which is associated with a higher cardiovascular and neurodegenerative risk. In addition, also eicosapentaenic acid and docosahexaenic acid and linoleic acid also reduced. Eicosapentaenic acid 11 and DPA 17 was decreased, 16 decreased, and linoleic acid was also reduced, 23. after treatment with high dose omega 2000 milligram, her laboratory findings improved, and her MOCA scale, because we assess with some cognitive scales such as Montreal Academic Scale, Mini Mental State Assessment Scale, and Frontal Assessment Battery Scale after treatment with drugs for Alzheimer's disease and with higher dose omega-3, your memory and attention was improved. This is our mechanisms. This is our prevention and therapeutic strategies. For my patients, I recommend physical activity, especially aerobic exercise, because aerobic exercise it's very good for our hippocampal and our neurogenesis, because especially aerobic exercise increased brain-derived neurotrophic factors and reduces insulin resistance and controls body weight and hypoglycemia. Also, nutrition, it's so important because Mediterranean and low sugar and omega-3 of acid and folate, B9, B12, B6, and it's very important because they decreased our homocysteine levels. And also I treat with pharmacotherapy such as metformin if patients have diabetes, and microdosing lithium, especially 100 milligram per day. And cognitive reserve, it's so important, especially education, intellectual engagement, social connection, sleep hygiene, stress control, and alcohol and smoking reduction. Cognitive decline is a multifactorial process. It's not about one factor, and this presentation it's I think illustrate that this is not about hypertension, it's not about insulin resistance, and we see so many factors, so many modifiable factors, and especially lithium inhibits, and I think that up to 40% of dementia cases may be preventable through sustained lifestyle modification and metabolic risk factors. Thank you so much for this opportunity. It's my final slide.
Thank you. Thank you, Kamila, for this beautiful lecture and enlightening us on treatment of, various kinds of dementia and their prevention. Thank you. So I'd like to invite Professor Wozniak first for his comments.
Can you hear me?
Yes.
Yes. Okay. Dear Kamila, thank you for excellent talk. Thank you that you reminded us that not only structural things which we can fix during neurosurgery, there are in the human brain. There are how much the genetic and metabolic factors are important for normal health. Your talk shows how much is important to cooperate, the cooperation between neurologists, neuropsychologists, and neurosurgeons. So we must work as one team. You presented the mostly metabolic cases, but I believe that you deal with patients who were treated with chemotherapy, with radiotherapy, and your option is very important, and your experience also is important for management of patients like this. So thank you very much, and I wish you big progress and big cooperation in your neurological, neurosurgical team. All the best. Thank you.
Thank you.
Thank you, Dr. Wozniak. Dr. Ikawa, your comments, please.
Thank you. Thank you, Dr. Kamila, for the presentation of metabolic factors in cognitive decline. especially regarding the lithium or omega-3 index is interesting. And can I ask the question?
Yes, yes.
Okay. Is it advisable to take lithium daily as a supplement before cognitive decline in all people? Can you recommend?
Yes, thank you for this question. I recommend supplementation before my cognitive, before I check cognitive scales, because it's so important, and especially because our patients with dementia not in our food, I think not many minerals or vitamins nowadays, and I give some treatment with vitamins or minerals because it's so important for our brain, especially omega-3, vitamin D, and our gut microbiome also.
Okay. And is it possible to diagnose lithium deficiency by any examination? Can you?
Yes, in Kazakhstan we have some blood tests, especially such as lithium, omega-3 index, and with, for example, our blood analysis, and before. After cognitive, after assess cognitive scale, after I check cognitive scale, I also recommend some analysis, especially glycemic index, insulin, and some blood tests, lithium, and the genetics tests. After that, patients, get this test.
Okay, thank you. And how long does it take for cognitive function to recover after lithium administration?
How long it's depends on patient, depends on stage of dementia. Because, for example, if patients come with mild cognitive impairment, we may stop this mild cognitive impairment, and patient's recovery, for example, after 6 or 9 months. But it's so long process. It's not about one patient; it's about patient's relatives. Because many patients needed help with relatives. It's so important.
Okay.
But patients with dementia, so long time, and for example, 2, 3, maybe 4 years.
Okay, thank you.
Thank you so much. Thank you.
Yeah.
Yes, Ben, you had a question?
Yes, and thank you, Kamila, for these great topics. So yeah, I'm really impressed with your presentation. I'm so glad that we have a neurologist here to teach us something about the cognitive or the neurodegenerative disease. I learned from Professor Cato recently that enough sleep may be the only solution to prevent the dementia. But I think, like, from the literature, more and more neurosurgeons are starting to work on these topics, like DBS or some other surgical interventions. So I would like to ask about, particularly for the Alzheimer's disease. So the current hypothesis is that the accumulation for those brain waste, like tau protein, and will cause those neurodegenerative disease. So from the neurologist perspective, do you agree on these hypotheses about the brain waste? And my second question is about, for those neurodegenerative disease like Alzheimer's disease, I would like to ask about what is the current update for the medical treatment. I think that there are more new drugs coming, but they are only to stop the disease progression for a short period of time, is around 6 months. So I would like to ask about your expert opinions from a neurologist perspective. Thank you so much.
Thank you so much for this great question. If we talk about second question, for example, nowadays we have some drugs, anti-amyloid drugs, named lecanemab and donanemab, but we have some good evidence, but in my opinion, it's not enough because Alzheimer's disease is not it's not about one factor. It's about multifactorial disease. And it's not about lecanemab and donanemab. I think it's, for example, hygiene, sleep hygiene, physical activity, and especially supplementation. It's so important for patients because some, for example, if we talk about with to lecanemab and donanemab, these drugs side effects, especially as hemorrhage, and it's so hard for patients. And in my opinion, we should check patients multidisciplinary and multifactorially. And can you repeat, please, first question?
Yeah, my first question is from neurologist perspective. So the current hypothesis, the updated hypothesis, is still the concept of brain waste. That means the CNS amyloid and also the tau protein cannot be excreted out from the CSF circulation. So is that the current hypothesis, or is that valid from a neurologist point of view? Thank you so much.
Thank you so much. It's a good question because nowadays we see that in our cerebrospinal fluid, we see production tau hyperphosphorylation and beta amyloid. But in nowadays, the most important is beta amyloid 42 in the cerebrospinal fluid and hyperphosphorylation tau. But it's evidence, and when we sleep, after that we our brain clearance. It's and why it's so important hygiene and sleep. This.
I see. Thank you so much.
Thank you.
I think we can move on now for the short of time. We'll move to the next presentation. Has Professor Abuzer joined?
Yes, I think he's now in the panelist.
Kamila, can you stop sharing your screen?
Kamila, can you stop sharing?
Okay,
Yes.
so I'd like to invite my friend Abuzer for his talk next. He's going to talk on white matter guided strategies for the management of ventricular lesions. Abuzer,
please unmute. I can see you try to share the screen.
I'm very sorry for being late. I had a case, a hydrocephalus case. I had to manage this one. I will talk about the white matter tracts of the cerebrum and the relation with the ventricles and our strategy in ventricular tumors. I would like to thank the organizing committee. I worked with the Professor Wharton in the University of Florida and learned how to dissect the white matter dissections, and with Professor Pamir in Turkey, how to manage the ventricular tumors. Then lastly, I worked with the Neurosurgery and still working with the Professor Ture. And I'm the director of this lab. We have 140 fellows. And if you want to look at our laboratory, we just published a paper about our laboratory. And these are the photos from Neurosurgery, the time before the tractography. You can see the all tracts and their colors. They are very similar to tractography, but before the tractography time. And we know there's a complex white matter tracts in the the lateral surface and the medial surface of the brain. And previously, only 3 or 4 eloquent areas were known, but nowadays we know these areas related only for the language. As you see, maybe all cortex and the deep structures are eloquent, and we must protect all structures in the brain. And how we can detect these tracts and eloquent areas? Preoperatively, we can have MR tractography, functional MRs and MR tractography to detect the white matter tracts and their relation with the tumors. And intraoperatively, you can use the intraoperative neuromonitoring to detect these tracts and eloquent areas. And for the ventricular tumors, ventricular lesions, several, not a lot of approaches described to enter the ventricle. And which tracts are related to the ventricular approach? We are looking from the lateral surface. You can see the superior longitudinal fascicle. It is located, and the arcuate fascicle located the lateral surface of the ventricles and related the language, and also arcuate fasciculus. You can see its relation with the ventricles. The ventricles is transdominated, and also middle longitudinal fascicle going from the temporal to the parietal lobe. And when we open the insula, the extreme capsule and the insula, and their relation with the ventricles, and also the external capsule, including the IFOF and the insulet fasciculus, and their relation with the atrium and the frontal horn. And also deep structures like the putamen globus pallidus and their relation with the ventricles. I will show some cases located in the lentiform nucleus, and the anterior commissure and the anterior commissure fibers located the lateral to the atrium of lateral ventricle, as you see. And also the internal capsule fibers and the optic radiation located the lateral wall of the atrium and the temporal horn. You can see the optic radiation and its relation with the ventricles. And lastly, the tapetal fibers. It's covered the lateral wall of the atrium and the temporal horn. And medially, we have the corpus callosum and the cingulum fibers located to superior, posterior, and inferior to the ventricle. This is the cingulum, and these fibers are the callosal fibers. And when we look from the superiorly, you can see the caudate nucleus, thalamus, choroid plexus, fornix, and we remove the thalamus here. You can see the internal capsule fibers and the anterior commissure and the posterior commissure pineal gland and the third ventricle. And also we published some articles about each approach and the relation with the white matter tracts. And also we have published several articles about all these tracts and the relation with each approach. And we described all white matter tracts and the relation with each approach to the ventricles. And firstly, we will talk about the tumors and the lesions located the frontal horn of the ventricles and the third ventricle using with the foramen mono. As you see, if you go from the lateral surface, you must go to the callosal fibers and the cornea aduata and the supralongitudinal fascicles. But if you go to transcallosally, you only go to a bit callosal fibers, but you must know all anatomy. This is the pericallosal arteries, and you must go interhemispherically and callosal. You can see the corpus callosum here, and not like in this video, but you must preserve all bridging veins in this interhemispheric and the supracerebellar approach. I always using the semilateral or lateral position for interhemispheric approach to use gravity. And as you see, this is the tumor. I think the pathology was the subependymoma. As you see, also you can use these transcortical approach, but if you go this approach, you must, as I showed before, you must pass the cornea aduata fibers, callosal fibers, and some supralongitudinal fascicle fibers. The less invasive way, the transcallosal fibers, as you see, the postoperative view, only 1.5 centimeter callosotomy, you can resect this kind of tumors. Even it can be bigger, you can resect this kind of tumor. And also for thalamic lesions, you can use this way, callosal transventricular way to reach the thalamus. As you see, this is the postoperative view. We went to the corpus callosum, then entered the thalamus and removed the tumor. It is difficult to reach with transcortically. As you see, there's a long way to reach this area. And also, this is another thalamic tumor located a bit posteriorly, but you can reach from the anterior interhemispheric transcallosal way. This is the postoperative view. You can reach all this area. You can use the ipsilateral or contralateral side. I always, not always, I am trying to use the right side because of the non-dominant, because of it is the non-dominant hemisphere. If the lesions locate the left hemisphere, I'm using the contralateral approach. But if the tumor is located to the right side, I'm using the ipsilateral way. And also, this is located deeper than the thalamus. This is the globus pallidus tumor. Also, as I showed before, and there's the relation with the ventricles, there's no more way to reach these tumors without any deficits, because as you see, this is the internal capsule fibers located lateral to the lesions after resection. You can see appropriately, we can detect with tractography. If you go from the lateral surface, you must pass to the internal capsule, and the patients would have deficits. But with interhemispheric way, we only use the anterior limb of internal capsule to reach and remove these tumors. And also the third ventricular tumors, you can use also transcortical, the endoscopic way, and also transcallosal interhemispheric way. As you see, this is our postoperative view. We also published this article. Our approximately 5 to 7 millimeters postoperative calloscopy we have. This is the postoperative view, and you can see all the transcortical areas, no T2 chains, only a small callosotomy. You can reach this kind of tumor. And then, as you see, the mostly white matter thorax locates the lateral surface, and then we will talk about the atrium. As you see, the lateral surface covered by the optical radiation and the tapetal fibers, and also in dominant hemisphere, the arcuate fasciculus covered the lateral wall of the atrium and the temporal horn. And also these are the challenging case for neurosurgeons. As I said before, if you go laterally to optical radiation, it can be damaged. And this is a ventricular meningioma. We removed the transfocal cortical way. As you see, there's a big damage of the cortical tissue. Only use the transcortical way, but if you use the translateral way, you will damage the optical radiation, and you will have this kind of visual area. You can see the visual area deficits here. Because of this, with Professor Ture, also Yaşargil described the posterior interhemispheric transperitoneal way to use these area to preserve the optic pathways and optic cortex. And then with Professor Ture, we described to use the parieto-occipital fissure to enter the atrium, not the peritoneal cortex. We dissect the parieto-occipital fissure and enter the atrium. Also, we use a lateral or semilateral position for these tumors to use the gravity. As you see, after opening the interhemispheric fissure, we put a cotton, and with ultrasound, we describe the relation with the tumor and the cotton, then enter the atrium, and this is after removing the tumor, we check with the endoscope, and this is the postoperative view. We use only these sulcus to enter the atrium. This is the preoperative view and the postoperative view. As you see, all the optic thorax are preserved. And also, when I present this case, we always discuss if it is located laterally, because it is a bit difficult. But after entering the atrium, you can resect any kind of tumor inside from the atrium. As you see, sometimes without entering the cortex, also you can see the tumors goes to the quadrigeminal system. This is the postoperative view. With a posterior interhemispheric way from the quadrigeminal system, with the help of endoscope, we remove without entering any cortical tissue. This is the postoperative view. Even it's bigger, you can remove this kind of tumor. I want to show. You can think there is a not thick cortical tissue, but when you remove the tumor, you can see there is a thick cortical tissue. All cortical pathways, like the optical radiation and the arcuate fasciculus, located here. And also this is another tumor located to atrium, a big tumor. This is the postoperative view. We use the parieto-occipital fissure to remove this tumor. And also, what is the most lateral area to reach from the interhemispheric way? You can see there's a cavernoma just located the lateral of the atrium. the optic radiations goes lateral to this area. If we go from the lateral surface, we can damage the optic radiation. Because of this, we use the posterior interhemispheric way to remove these paranormal. Then lastly, the temporal area, it is similar to the atrium. The optic radiation and the language pathways like the arcuate fasciculus, I4, all they are located lateral to the temporal horn. And also this is a sagittal stratum. Sagittal stratum means all structures emerge with each other. Which structures the anterior commissure fibers of I4 and the thalamic fibers. As you see, this is the lateral surface of the temporal horn. This is the I4 and the anterior commissure fibers to optic graduation. As you see, there's a complex white matter thorax area located the lateral of the temporal horn. You can reach these models from these articles. As you see, this is the temporal horn and the lateral surface covered by the sagittal stratum. And what can we done for this kind of tumors if we don't want to touch the lateral surface? There's two approaches described by the Rashagil and Professor Dure. As you see, if the tumor is located to hippocampus and laterally, you can reach the supracerebellar transtemporal way. And also we use the semi-sitting and sitting position and the lateral semi-sitting position to use gravity for supracerebellar approach. And also this is the postoperative view. As you see, we preserved all structures lateral to the hippocampal structures. Only remove the hippocampus and the hippocampal structures. And this is the postoperative visual area. And also, we will publish the all steps with animations. The supracerebellar transtemporal approach to the mesial temporal area. You can see the incision and our burr holes. We always use burr holes to above the transverse sinus, two burr holes for transverse sinus, one above and the one below. And after opening the craniotomy, we open a small incision to release CSF from cisterna magna, then open the dura, then open the tentorium to release the parahippocampal gyrus, then remove the parahippocampal gyrus and remove the tumor. This is the view after removing the parahippocampal gyrus. You can see the parahippocampus and the ventricle. You can reach, and you can see also, we can see the anterior circulation arteries from this view with the endoscope. As you see, after removing the tumor with the help of endoscope, you can see all these structures. This is the ICA, optic nerve. All hippocampus and amygdala removed, preserving the lateral cortical tissues. And also, if the lesion located anteriorly, you can reach the transsylvian way to reach these tumors. This is the preoperative and the postoperative views. As you see, we preserve the lateral surface of the temporal lobe, and also all white matter tracts. Also, I would like to invite you to our Istanbul Rashid Neurosurgery course in June. And also, we will publish soon all models in internet. In my knowledge, this is these models have the highest quality now. As you see, all small nerves and any brains and all cortical areas. And also with this QR code, you can look these models like this. You can see a link, and after allowing the link, you can put your model anywhere you want. From the medial surface and the brain stem. And also we published in the Neurosurgical Atlas. You can reach all these models from the Neurosurgical Atlas, the 3D photos, and they all are models, but the previous model, a bit low quality, but you can reach any structures and learn about what method tracks. And you are welcome to visit our laboratory in Istanbul, in Yeditepe. All these works coming from this kind of laboratories. Also, Abida has a lot of good articles and studies about what method works. Thanks for listening.
Thank you, Abuzer. That was a very beautiful presentation with 3D models and very educative. So, it becomes easy to get a three-dimensional perspective by looking at these models and a different way of looking at things. So thank you very much. And I will be talking about it and then we can discuss later. So I invite first Professor Wozniak for his comments.
Thank you. Thank you, Professor Güngör, for excellent talk, excellent lecture, quite a discussable lecture. Your idea to avoid all the fibers on the lateral part of the lateral ventricle, of course, I support it, but in practice, we cannot avoid the transcortical approaches to the lateral and the third ventricles, in fact. So idea is good. My criticism is towards the transcallosal approach. It's not a universal approach, unfortunately. It could be used only in limited series, in small tumors. First of all, because of trauma of veins, adhesions, and you are very limited when you perform the callosotomy, not more than 1 centimeter. If you do bigger or traumatize bigger, patient will have disconnecting syndrome, which is very severe in postoperative, and maybe the functional deficit after cortical approach could be much less and even not noticeable for patient if you will go through the middle frontal lobe to the anterior horn. And from the next step, when you go transcortically, you can use endoscope and work with endoscope. To work when you come by transcallosal, you're quite limited in your activity with the endoscope in the wound. It's possible, of course, but it's so that is why idea is great. But in practice, I think we must keep in mind that we can use the lateral approaches also, as well as lateral approach through the middle temporal gyrus to the lower horn, which is maybe traumatic, but sometimes it's the best way to go this shortest way. The another problem that it's very difficult to monitor the associative fibers during surgery. Even with the wake-up anesthesia, we can control the movement, we can control speech, some emotions, but it's very difficult to control the associative fibers. There are some methods in experience, but they are not in practice, and we cannot use it. And the way of these fibers also is very individual, and it's very difficult to predict the result of our transcortical approach. So thank you very much. Thank you very much. You showed great cases. You showed great preparation, great specimens, very well prepared. And so I wish you to move ahead, to develop this, to move in this direction. And my congratulations with this great talk. Thank you.
Thank you, Professor. I can say something.
Yes, why not? Why not?
Yes, you are right about the interhemispheric approach, a bit difficult from the transcortical approach because of the bridging veins and also the pericallosal arteries and also medial cortical structures. But I am lucky because I have learned this approach from Professor Ture and discussed with the Professor Yashagin. And I think I don't know the exact case numbers, but I think the Professor Ture had maybe 1,500 interhemispheric cases, maybe more, I don't know. But I don't see any vascular damage on this approach. Also, I have almost 200 cases with interhemispheric approach. I didn't see any the venous sacrification and also any damage of the medial cortex. Maybe because we learned from the Ture and the Yashagin, we avoid anything to damage these veins because we detect all the bridging veins before the operation with venography, and we select our craniotomy site and location after detecting all these bridging veins and using the gravity and also after entering the ventricles, all the interhemispheric area released, and you can reach anywhere you want to reach. You are right, a bit difficult, but the young neurosurgeons must learn and try to reach this way, because as I showed, this is the less invasive way. If you can reach these areas without touching the veins and arteries, you can reach with less damage to white matter tracts.
Yes, Abuzer, for this I agree with you actually, that the interhemispheric transcallosal to the ventricles is the best approach, because that is the minimal damage to the white fibers. Some tumors may be, like left atrium projecting laterally, or medial temporal tumors, I will differ a little bit, but majority of lateral ventricular tumors, I will also prefer the interhemispheric transcallosal. Sometimes what we do is, if the tumor is too big and you cannot reach the corpus callosum, so you can retract the superior frontal gyrus and go through the cingulum. It's not a very great thing, but sometimes the tumor is so large and you straight land up in the corpus callosum, in the ventricle, you will release the CSF and you will get the tumor. So this is also, we've published our experience, I think, on 145 lateral ventricular tumors, all operated interhemispheric. So for this, I agree that corpus callosum interhemispheric is a good approach. Professor Ikawa, your comments?
Thank you. Thank you for your Professor Abuzer Güngör, the wonderful approach, and your preoperative simulation by using the tractography, and not only tractography but also the venography. I can understand. And deep-seated lesion, you use many approaches for thinking the tractography. So I have the question. Do you differentiate between endoscopic and microscopic surgery? Can
you want to say the pure endoscopic approach, lateral approach to the ventricles?
Yes. In this case, you only endoscopy. You use endoscopic or microscopic with endoscopy.
Microscopy with the help of endoscopy. Yes, we always check with the endoscopy, but not pure endoscopic approach. We only use endoscope to check the after removal, to check the area if any residual tumor.
Okay, I see. And when you remove the thalamic tumor located if the far from the ventricle, what is the best surgical approach, do you think? Okay.
We published these articles, also Professor Prof published. All thalamic tumors can be removed any part from the interhemispheric and the supracerebellar wave. We described and we published these articles. All, if it is located the anterior and superiorly, you can reach where the interhemispheric way, and if we locate the pulvinar part, you can reach with the posterior interhemispheric way, and also if it is located the inferior part, the thalamus and the lateral geniculate body, you can reach with the supracerebellar transtemporal way.
Regardless of the size and the location.
Yes.
Okay. I see.
But I always try to select the anterior interhemispheric way because in transcallosal anterior interhemispheric way, also I have a chance to open the tuberosum and make a third ventriculostomy at the in the approach, in the operation.
Okay. And apart from classic neurological deficit such as hemiplegia or aphasia, which white matter tract do you take the most care to avoid damaging?
To avoid these risks,
for example, the cognitive function. Do you care the cognitive function?
Sure. Any function, we try to care any function and any areas in the brain. Because of this, we want to share our opinion to preserve any white matter tracts during your approach. Because we know, as showed before, we know only several areas, the eloquent areas like the language areas and the motor areas. But nowadays we know all cortex are related any kind of function, and also we don't know which tracts are related. We only know the language, some motor areas, but about the some how can I explain? Because the brain and the functions of the human brains is very complex, not only the motor and the language and the vision, more complex than these hours. Because of this, we try to preserve any white matter tracks.
Okay. And what kind of software as a preoperative simulation do you use?
Yeah, we are using HoloLens. Maybe you know there's a
HoloLens.
yes.
Oh.
We can also
What's the company?
HoloLens company.
HoloLens company.
Yeah. I think the
Not in Japan.
company-
Okay. Thank you. Thank you very much.
Thank you. Thank you, Dr. Ikawa. Ben, should we go ahead or?
Yeah, I think we should go ahead for the sake of time. Yeah, and really a deep and interesting discussion. I think we all learned so much from the discussion. Yeah.
So then I'll just share a few slides on one learning point. Since this talk was on white fiber dissection, I will just continue with some opinions on this thing. So the topic is nothing is non-eloquent, white matter and neuro-oncological resection. So we are used to seeing images like this. Abuzer showed us some beautiful images now. So you see tractographic images, you would have functional MRI on that, then you can make 3D models. But very soon we are going to be dealing with such kind of images. So this is a connectomic map of this patient. So this is the tumor. And what are you seeing in relation to the tumor? So you're seeing these networks. So this is the language network. The one that is lighted up is the network. This is the visual network. So in relation to this tumor, the visual network will be the most important to study. This will be the sensory motor network, the salience network, the central executive network, and the ventral attention network, which is again important in this tumor. So when you are approaching these tumors, you have to look at it not just with white fibers, not just with cortical structures. You look at it as a whole network. And you have to approach the tumor and you have to learn to preserve this network. So this is how we are going to progress in our neurosurgical resections while approaching intraaxial tumors. So basically the whole human network is consisted of cortical areas, which I like to call nodes, and they're connected by a series of subcortical network, that is the white fibers or the edges of the links, and this whole structure together. So the cortex along with the white fibers, they form a fascinating grid of function. So the whole anatomy is hodotopic. And this is an image from Yeo et al. Atlas. And he has defined these major networks that have been identified in the human brain. These are only 7, but a recent analysis is now identifying 17 networks. But these are some of the major ones that we should remember when we are dealing with tumors. So I will just show you an example of these networks by demonstrating this language network. So there are 2 main language networks, that is the semantic network and the phonetic, the dorsal and phonologic network. So the semantic is the ventral pathway, and what are the structures that are involved in this network? So the superior and middle temporal gyrus, the superior temporal sulcus, the dorsolateral prefrontal cortex, the angular gyrus, the pars orbitalis. And what are the fiber tracts that are involved in this network? So that you have the IFOF, that is the direct fiber connection, the most important one. Then you have the ILF, the uncinate fasciculus, and also the middle longitudinal fasciculus. So if you damage anywhere in this network, the cortex, subcortex, if you damage here on the dominant side, you will get semantic paraphasias. On the non-dominant side, you'll get non-verbal comprehension disorders. So similarly, that phonologic or the dorsal pathway, the important substrates are the inferior frontal gyrus, the middle frontal gyrus, the superior temporal gyrus, and the most important fiber bundle is this one, the arcuate fasciculus, and the SLF3 is the indirect pathway. So to understand these networks, it is important to understand both the cortical structures and the subcortical network, and then you will be able to do safe oncological resections. So I think many of you have presented this before. This is our classification of white fibers. So the first layer is the short arcuate, the second layer is the middle layer of long association fibers, then you have deep fibers in relation to the ventricle. This one is the commissural fibers, and this is the vertical group of fibers. Now we see this beautiful brain without the pia and the vasculature. And when we look at it, we have tried to think, how are we going to approach an intraaxial brain tumor? I'm not going to go into the cortical anatomy, but the first fibers, actually, we don't pay too much attention to these fibers. And these are the short arcuate fibers. You see how delicately they are connecting two gyri to each other. They're connecting distant gyri to each other. They're connecting gyri on top of the white fibers. So this is a very important short arcuate connectivity that we are not studying. And recently we've published this of how various short fibers of the brain connect with each other. So there are intergyral fibers, there are intragyral fibers, and there are linkages between the two gyri. And very recently we studied this anatomy. So we are all used to hearing Professor Yasargir say that you should go transsulcal. You should always prefer the transsulcal approach. And why do we say that? Because we think that the cortex has some eloquence, but and that you are trying to avoid injury to this eloquent cortex. But you must remember that when you're coming from within a sulcus, there is a layer of white, there is a pia and arachnoid here with blood vessels. So you have to manipulate the vasculature when you're going transsulcal. And the second thing that not many of us studied is the anatomy of the short arcuate fibers that we are transgressing when we are going either transcortical or transsulcal. So what happens here is when you're going transcortical, as you can see here, you're running parallel to this vertical intragyral fibers. And when you're coming transsulcal, you will actually go through these vertical fibers, and you will also go through fibers that connect the two gyri to each other, and also fibers that connect the cortex to the long association fibers. So, in this article, we wondered whether the transcortical approach is actually better or the transsulcal approach is better. So if those of you are interested can read this, and the anatomically subtleties of this have been described. So we saw a lot of models in the presentation. So when you're going through the cortex, so when you're going through the sulcus, what are the fibers that will come? So when you're going through this middle frontal gyrus, you will see SLF2 here. When you're going through the inferior frontal gyrus, at the depth, you will have SLF3 and the arcuate that is going perisylvian. In this region, in the region of the Lyman, you'll have the uncinate and the IFOF. In this region of the superior and middle temporal gyrus, you'll have the Mayer's loop of optic radiations. And in this region of the inferior temporal gyrus, you'll have the ILF. So you should have this 3D mindset in your mind when you're approaching intraaxial tumors. I'll just show this quickly. He has already shown it beautifully. So the arcuate fasciculus, the SLF, this is the corona radiata, this is the uncinate, the IFOF, this is the ILF. Once you lift the arcuate, this region is the sagittal stratum, and this region here is the temporal stem. The sagittal stratum has a series of fibers, which Abuzer has shown. And when you come from laterally, as he said, the internal capsule is your limit. Beyond this, you will have the basal ganglia, you'll have the ventricle. So the internal and external capsule cover the putamen, and then beyond it, you'll have the ventricle. When you come from medial, you have the cingulum, and you have the whole limbic network. So when you're coming from medially, the network that you have to consider is this limbic network and how to approach tumors without damaging this network. And when you do the same dissection from medially, you will come across this thalamic radiations that form the medial limit. So here you can see that we've dissected the Pape circuit. So this is the fimbria, the fornix, the columns of the fornix, the mammillothalamic tract, the antenucleus of thalamus, anterior thalamic radiation, then the cingulum as it turns back here to come to end in the hippocampus or the entorhinal region. So this whole circuit is one of the circuits of the limbic system. There are many others, and those of you interested can read this. This is the Papis circuit we reconstituted outside for the first time. The whole limbic network was dissected outside from the brain. Now, as we saw today in the interhemispheric approach, this anatomy of the corpus callosum is most important. So you have to understand the corpus callosum actually covers the whole ventricles. It is enveloping the ventricle completely. So even if you're coming from laterally, at some point you will cross fibers of the corpus callosum. So these are anterior callosal radiations of the forceps minor. These are posterior callosal radiations of the forceps major. These ones are the dorsal callosal radiations, and then there are radiations that turn down, and that is the ventral callosal radiation. So here you see posteriorly there the tapetum, which forms the roof and the lateral part of the temporal horn and atrium. And anteriorly you have connections that connect both basal ganglia to each other by the ventral callosal radiations. So among the safe aspects of performing a callosotomy, it is either here anteriorly or just in front of the splenium in the region of the isthmus. This is a no-no, and here in this circle is a complete no-no for entering the corpus callosum. Another thing that I would like to point out that the corpus callosal fibers are transverse. So it is always better to make your callosotomy transverse so that you splay your fibers and you enter the ventricle instead of making a longitudinal cut. And you're performing a callosotomy for epilepsy, you have to actually go from this end to that end to disconnect the whole thing. That's when you cross this area. Otherwise, it will be incomplete and you will have seizures. So these are the networks that you should take care of, and these are the injuries that happen when you damage this network. So you damage the SLF, you will have speech arrest, dysarthria. If you go to the arcuate, you will have repetition errors, phonologic paraphasias. In the IFOF, you'll have semantic paraphasias. In this region, you will have syntactical errors. So you have to remember these deficits when you're operating on tumors. So this diagram is from Professor Yasser Gill's textbook, and he has said that this is how the pattern of gliomas grow. They grow towards the ventricle, and they try to follow the callosal fibers as they go towards the ventricle. Now we have speculated that the gliomas originate from stem cells, that they originate from the subventricular zone, but they migrate to the subcortical level, and that's where the tumors arise from. So if you understand the pattern of white fiber, you can identify the white fiber that is involved in this tumor. So if it is we have divided into localized and diffuse. So if it is a localized tumor, it is arising from the short arcuate fibers of the gyrus. If it is a diffuse one, you can see that it is going along the long association fibers, or it is going along the corpus callosal fibers. So by radiologically and anatomically understanding these fibers, you actually can identify the white fiber tract that it is originating from and growing along, and it is displacing the other adjacent normal tracts. And you can see these are our papers on the subject. I will just give you 2-3 examples of tumors and how I think when I'm operating on them. So you see this tumor, it is right in the precentral gyrus, just anterior to the precentral gyrus. You see this DTI tractographic images that are bordering this tumor. Here you see the functional MRI that are going through this. Now, when I'm thinking of this tumor, I know I have to preserve the motor system. That is the most important network, the sensory motor network that I have to preserve when I'm approaching this tumor. Now, my understanding also says that this is a localized tumor that is arising from the short arcuate fibers. So the long association fibers or the vertical group of fibers are displaced. They are not damaged. Now, this patient ideally should be done awake with monitoring. However, our patient was not at all cooperative for awake surgery. And here you see that by just my understanding, I have used sonography to define the margins of the tumor. I can see it visually, but just to confirm, I have used this sonography. And you can see that I'm separating this tumor from the motor gyrus. Actually, I'm separating it completely from the precentral gyrus and then operating on it. Here you can see that this is the precentral gyrus, and I'm defining this tumor and separating it from the precentral gyrus. Subcortically, I know where the fiber tracts are by this anatomical knowledge and by the direction and depth of these fibers. And you can see that I've done an en masse resection of these tumors without any problem. And here you can see this is my patient. Here you see the post-operative image, the whole tumor is out. This is the pre-op and the post-op sonography. You can see the post-op tractography where the fibers are completely maintained. And this is he's talking, he's moved. He had some weakness in the right side before surgery. That weakness was still there, and this is 3 months after surgery. And here you can see that his right upper limb is completely normal. He's able to lift hands and do all kinds of activities with this hand. So this is the concept You have to understand this concept, and then you can operate on these tumors. Similarly, when you're looking at tumors in the SMA region, you have to understand this network. You have to understand that the fibers, important here is the SLF here, the cingulum, and the corpus callosum, and of course, the frontal Ashland tract. So this is the tumor. This is in the supplementary motor area. So many people have started advocating negative motor mapping. In this, you try to map out areas which are negative for motor tasks and then do an excision. In this, what happens is sometimes you leave a small amount of tumor behind. So using our anatomical knowledge, we've realized that if you preserve the cingulum, if you do not go beyond the cingulum, you will not laterally cross the frontal Ashland tract. So you will just remove the tumor and you will avoid having the SMA syndrome. So you see, this is the post-op excision of this tumor that I've done. And this is in the immediate post-operative period. There is no SMA. This patient did not develop an SMA syndrome. So it is anatomical knowledge that is important. When you're operating on the insula, the two important networks are the language networks, the semantic on the phonologic pathway. And I'll just not go into these details, but this, of course, is a tumor in the inferior frontal gyrus in the pars opercularis. And this heralds a wide open, awake surgery. But some of our patients are not cooperative. You cannot do the surgery. You have to find a solution. And our solution is anatomy and understanding of this. And what you can see that is speaking immediately. This is the second day after surgery. And this is an insular tumor. Here you can see I have done this on the left side. You can see the excision. Just a very small amount of tumor is left, again, without any monitoring, without any awake surgery. It is the anatomical understanding. It is doing multiple white fiber dissections and understanding where the tumor is, and then you can do. So we discussed the supracerebellar approach, the transsylvian approach, but there is an approach, as Dr. Wozniak was saying, through the middle temporal gyrus. And if you know the parameters of this approach, so in the most anterior part of the middle in the temporal horn is devoid of any fibers of these optic fibers. They are in the roof and more posteriorly than the lateral wall. So if you enter the ventricle in this region from the middle temporal gyrus, you will avoid injury to this IFOF and the optic radiations. Professor Goel described this approach for epilepsy, and we use it to also do our mesial temporal tumors. So this is a tumor in the uncus and involving the amygdala. And here you can see the approach I have taken through the middle temporal gyrus, and I've removed the tumor without causing any visual deficit. This is a tumor involving both the amygdala and the hippocampal head. Again, gone through the middle temporal gyrus, and you can see actually a supramarginal resection for these low-grade tumors. Now, lastly, this is a tumor of where is this tumor? It is not a corpus callosal tumor. It is a tumor of the cingulum. It is arising from the isthmus of the cingulum. And once you recognize this, the best approach, of course, is interhemispheric. You will avoid all fibers, all the forceps major, the optic radiations, everything will be avoided. And this is the approach to remove these tumors. So again, you have to understand the anatomy. You have to understand the network that you do not want to damage. And that is how you can approach these tumors. For those interested, can read my book. And I would like to invite you all in July and August to the 15th ACNS to join us for our Congress with Professor Kato. Thank you very much. And I think I can open the floor.
Yes. And really great talk with us as always. And without due delay, I'll invite our comments from our discussion. Professor Lisek, any comment?
Thank you. Dear Abuzer, thank you for great talk. Thank you. First of all, I absolutely agree with you that the transcortical way is much more safe than the transcervical, especially when we go through the gyrus near the eloquent areas. It's less traumatic and functionally much better. We came it in my practice. And like a conclusion of your talk, so we cannot avoid the transcortical approaches, but we can move like in between the drops of the rain to preserve all the functions and to reach the most radical resection. Only one point concerning intraoperative neuromonitoring. So I anyway, I insist on awake monitoring for patients when we work near the eloquent areas. I think it's more safe, and it has been shown that it's much better, it's more safe and functionally better for the patient, especially in the delayed functional results of the surgery. But in general, thank you. Great talk, great job, and hope to see you in Congress in Mumbai very, very, very soon. Thank you. Thank you.
Thank you. Thank you, Dr. Wozniak. So I agree that most of these tumors should be done awake and should be done with monitoring.
Yes.
And everyone who is not as well versed with the anatomy should definitely not try this without understanding. But sometimes, in our country, the kind of population I deal with, they do not, they do not cooperate. They do not understand. It is difficult to communicate. Even the cognition, to assess is difficult. So, but based on that, we cannot not do the tumors. So yes, when possible for insular tumors, I will like to do them awake. But in general, even without awake, I can do a good job. So, but for that, you should do the anatomy, you should learn the anatomy.
Great. I agree. Thank you. Thank you.
Great. Any comment from Professor Ikawa?
Thank you. Thank you for beautiful presentation by Professor Adi here. And many kind of surgery for preserving the functional fiber. And also I have some comment of the what kind of monitoring, intraoperative monitoring do you use in the this surgery?
So if majority of the times, to tell you the truth, I don't use monitoring. But if I do use, I use motor mapping. I use subcortical monitoring. And of course, if it is awake, then just the subcortical monitoring with bipolar and transcranial MEPs. But these are the main ones that we use. Okay,
thank you. And in the case of precentral tumor, you remove the macroscopic tumor resection.
Yes.
Which is better to remove the tumor, macroscopic or microscopic, to avoid damage of the central gyrus?
So I use the microscope for all my patients. I do not do anything without the microscope. So I use the microscope to remove the tumors. Sometimes we even use an exoscope to remove the tumors. Because a lot of my tumor resection depends on the visualization and the feel of the tumor. So it is better with the microscope. You can actually make out the difference in texture. So I don't do anything without microscope. I use the microscope, and I would prefer to use the microscope.
Okay, thank you. Thank you very much for your beautiful presentation.
Thank you.
And success.
Great. And any comments from Professor Abuzer? It's a good lecture after your bimetal lectures.
As always, Abida explained anything which I couldn't explain. Thank you, Abida. I want to say there's no eloquent area in the brain, and also thank you, Abida.
Thank you, Abuzer.
Great. Anuyaku, you raise up your hand.
Yes, thank you so much, Ben. Yeah, thank you, Professor Abida, for this wonderful presentation. Yeah, your unit, you always, while maintaining the legacies, you've kept raising the bar in access to tumors. Yeah, thank you so much. I've always known that the anterior third of the corpus callosum can be used to assess tumors, especially ventricular tumors. But in this presentation, you made us know that while the anterior, okay, then the posterior third, where you have the splenium, because of the concentration of fibers in the splenium, you try to avoid the splenium. Yeah, but in the presentation, you said the anterior third and then the posterior third, where you have the splenium, can be used, but the middle third should be avoided. So please, what's the reason? Thank you so much.
So, Naiku, anterior third, I'm going above the premotor and motor area. Okay. So the area I showed, the callosotomy, is in front of the foramen of Monro, generally. Okay. So where the foramen of Monro is at that level, just beyond that will be the SMA region, will be the motor region. So I don't want to perform a corticectomy in that tract because the fibers, the callosal fibers are connecting these areas across. And posteriorly, I do not make the corticectomy in the splenium. It is in front of the splenium. So it is in the region where the two precuneus regions are connecting to each other. So it is in the isthmus of the corpus callosum. It is anterior to the splenium. And when we are doing thalamic tumors, especially for the posterior interhemispheric route, I use that. I use the callosotomy in front of the splenium, and we have got good results with that without causing too much any disconnection, actually.
Okay. All right, thank you so much. I appreciate it.
Great. And I think with that, is about near the end of our great presentation. And I think we did have a really intense discussion about the anatomy, and also it's good to have a neurologist input for the dementia. Shall I invite comments from Professor Kato?
Sorry. So Dr. Kamila, thank you so much as a neurologist. So wonderful talk. I think dementia patients, especially in Japan and the Asian countries, so many increasing in number now. So I think, of course, dementia has started not the aged people, but also they started maybe 20, 30 years back. So we need to start the treatment at the time, I think. Even biomarker or some medicine or whatever, I think the earlier the better for prevent in the future. And also the Abuzer, thank you so much. So wonderful, the video, educational video. And it's quite easy for the younger generation, I think. So because Abida talks about fiber dissection, so many, because Abuzer says that recently so many eloquent lesion is increasing in number. So it's quite difficult for younger generation to touch the brain itself, I think. So maybe in the future, of course, the direct surgery plus radio surgery or some other modality they will need it, I think. And also, of course, that to know the anatomy, to learn the anatomy is most fundamental and very, very important for YNS, I think. Most the talk was very excellent. Thank you very much. I learned a lot. And also the Bosnian and also Ikawa Sensei, thank you very much for your great comment.
You're welcome.
Thank you.
You're welcome. Thank you.
With that remark, and I shall end this ACNS webinars, and it's a really great ACNS webinars today. And on behalf of the Educational Committee of the ACNS, I would like to thank to our chair, Professor Abidas, for chairing the section and the wonderful one-point lessons. And I would also like to thank two of our speakers, Dr. Kamila and Professor Abuzer Kong, and also our discussion today, Professor Wong-Siek and also Professor Ikawa. So I hope to see you in the future ACNS webinars, and hope to see you in person very soon as well. Thank you so much. Good night.
Thank you. Thank you, guys.
Thank you.
Thank you.
Thank
Thank you so much.
See you again.
See you
Thank you
next
so much.
time.
See you later.
Bye-bye. Thank you.